To get started. Thanks for coming, everyone. My name is Fahima. I'm a general surgery resident presenting a thesis proposal that's meant for a PhD transfer defense. So my project is called What Comes Next? The Uptake of Cancer Risk Reduction Strategies by Women Who Receive Inconclusive Results from BRCA1 and BRCA2 testing. That doesn't work. There we go. Okay, so I'm assuming you guys know a bit about breast cancer at the very least, but what I will emphasize today is that in women who have a family history of breast cancer, what we see is up to 20% of those women carry a pathogenic mutation in one of the breast cancer susceptibility genes, and the ones most commonly implicated in those women are BRCA1 and BRCA2 that we'll be discussing today. What does that mean as far as cancer risk for these women? Well, as I'm sure you know, it definitely increases the risk of breast cancer, upwards of about 70% in some of these women. But we also see an increased risk of ovarian cancer in these women, especially those who carry BRCA1 mutations, but also quite a significant increase in those with BRCA2 mutations as well. So the ideal scenario would be to identify women who carry BRCA mutations, identify people who would be at high risk for carrying BRCA mutations, test them, and then intervene in some way to decrease their risk of mortality from breast cancer or try and detect breast or ovarian cancer early as possible. Fortunately, since 2001, the Ministry of Health and Long-Term Care has been offering BRCA testing to women who meet one of 13 criteria. Although the screens are big, I don't expect you to be able to read any of those, but what I will point out is that these criteria are a combination of personal cancer history, family cancer history, and then some considerations based on ethnicity as well. Like I mentioned, it would be ideal to have women tested and then tell them definitively whether they have a positive or a negative test. Unfortunately, that's not the case. And what usually comes out of these tests is one of 4 results. So the result that's probably the easiest to understand and the most familiar to people is a positive test result. So those are women who are found to carry a risk increasing mutation. And for those women, the recommendations that tend to be made are one of 2 types. So those women can undergo high-risk breast cancer screening with annual mammography and breast MRI, or a conversation can be had with them about undergoing prophylactic surgery. So that can be a mastectomy or a salpingo-oophorectomy or both. The next category would be those women who receive a true negative result. And we see these most commonly in women who undergo what's called predictive testing. So someone in their family has already been found to carry a pathogenic mutation, and then they're tested for that mutation. And if they're negative, then that's a true negative, which means that their risk is akin to the general population, and they can undergo screening as per general population guidelines. The next group is those who receive a variant of uncertain significance. So this is a bit less familiar to people. And this is when a variant is found in one of the genes, but it's unclear how that changes their cancer risk, if at all. And then the final category is that of a non-informative negative. So the most common setting where we see this is if a woman is the first in her family to be tested and she receives a negative result. So that doesn't necessarily mean that she doesn't have a hereditary form of cancer, but she may have a mutation in one of the other genes. So that's one case where you can get a non-informative negative. And really these latter 2 categories, the recommendations for what to do with those women isn't as clear. What current guidelines tell us is to individualize their recommendations. So any recommendations that are made for them should be based on 2 things, their personal cancer history and their family cancer history. That sounds probably a bit more straightforward than it is. And I'll refer to those 2 groups as women who receive inconclusive results. And what we see in women who receive inconclusive results is that they actually struggle with this. So we see low rates of disclosure to their family members. We also find that they sometimes inaccurately perceive what their actual cancer risk is, and I'll show you some data on that as well. There's quite a bit of uncertainty in this group as to what they should do to reduce the risk of cancer or mortality from cancer. And this also has implications for healthcare providers who are often uncomfortable with communicating the risks, the implications of the results, and any further recommendations for care of these women. So as I mentioned, some of these women misinterpret their cancer risk, and this is a study where they interviewed women who had undergone BRCA testing and asked them 2 things, how they interpreted their cancer risk and what they recall the genetic counselor telling them about their cancer risk. And what I'll point out is that women who had variants of uncertain significance actually interpreted their risk quite similarly to those who carried pathogenic mutations. And even more interesting, the women recognized, up to 50% of them recognized that their interpretation of their cancer risk was actually much higher than what they recalled from the genetic counselor. And this is concerning because if women think their risk is much higher than it actually is, you can imagine that they might be prone to undertake some of those interventions I mentioned earlier at higher rates than they probably should. So unfortunately, we don't really know what these women are doing. We don't know if they're undergoing prophylactic surgery. We don't know if they're undertaking high-risk screening. Much of the data that we have is based on women who are found to carry pathogenic mutations. Much of the data that exists is survey-based. You can imagine there's some recall bias there that needs to be considered. And as I mentioned, we don't have a lot of data on these women who receive inconclusive results. And so we don't know if they're over or under testing or if their perceptions of their risk of cancer are really influencing the care that they're receiving. So my research question for this study is to determine whether these inconclusive results are independently associated with the uptake of high-risk breast cancer screening or of one of the two forms of prophylactic surgery. And I'm hoping to answer that question using a retrospective data linkage study. So I'll just walk you through the three components of my thesis that are relevant to today's talk. So the first part of it will be how we're going about creating the cohort that we'll use to answer these questions, the methods for a study looking at the uptake of high-risk breast cancer screening, and as well as the methods of a study that will look at the uptake of prophylactic surgery. So to begin with, the first aim, the cohort that we're creating, is called the What Comes Next cohort. And the nice thing is, so although genetic counseling in Ontario is quite distributed, genetic testing only happens at a few sites in the province. Two sites in Toronto actually make up approximately 2/3 of all the testing that happens in the province. They happen to be in and around the area of downtown, so we're able to take advantage of these sites and use these sites to identify women who have undergone testing. So the population for this study will be any adult women who have undergone BRCA testing, either at Mount Sinai Hospital or North York General Hospital from January 1st, 2007 to April 30th, 2013. We're expecting to have about 18,000 women who have undergone testing that will be included in our cohort. So once we've identified these women, what we're interested in is getting information about their cancer history and their genetic test results. We're doing that primarily through a chart abstraction process. And through these charts, there are two pieces of information that are most relevant to the variables that we're interested in. The first one is the requisition form, which also comes with a detailed pedigree of the family. So from that, we'll be able to ascertain many things, but importantly, we'll be able to pick up on the family cancer history, which is a bit unique for our data set. The other piece of information that we're obviously interested in is the genetic test results. So we'll be able to see not only which gene is mutated, if the mutation exists, but also what result was conveyed to the woman who underwent testing. So that process is already underway. We've created electronic data capture forms that we use REDCap to administer. We have trained 3 full-time chart abstractors who are involved in this process. And I checked our numbers this morning. We're actually almost 80% complete. So thank you to those of you who are in the room who are involved in the process. So once this is done, what we're hoping to do is to link this to health services data at ISIS. We'll be using certain population databases to pick up on patient demographics, health services databases to look at utilization. There will be some specific acquired cohorts that we're interested in. So the Ontario Cancer Registry will be used to follow these women over time to see if they develop cancer. And the Ontario Breast Cancer Screening Program, along with OHIP, will be used to look at uptake of mammography. And then some care provider databases to look at institution variables and physician-level variables as well. So with this, as I mentioned, about 18,000 women, that'll give us the largest cohort to date that'll have such granular information, especially looking at family history. So once that's complete, which will be soon, we hope, we'll be able to move to aim 2, which is that study looking at the uptake of high-risk breast cancer screening. So just to give you a bit of context as to why this study is needed, I'll start with what we know. So we know that somewhere between 20 and 50% of women who carry pathogenic mutations who don't undergo screening who don't undergo prophylactic surgery seem to undertake high-risk breast cancer screening. Like I said, these tend to be small survey-based studies, to take it for what it's worth. But we've also seen in some of these small studies that after testing, in some of these before and after tests, women who receive a VUS result seem to increase their levels of screening, whereas those who receive a non-informative negative do not. For those of you who recall that I said both of these groups should receive recommendations based on personal and family cancer history, it's a bit odd that we see this difference in the way that they screen. And so I think for this study, our primary interest will be on that VUS group. And what we're hoping to answer is, we're hoping to determine what the rate is of the uptake of high-risk breast cancer screening and whether that changes over time. For example, does that wane from the time of the test results? So to do this, we'll be using the What Comes Next cohort. We'll be looking specifically at women who don't have a history of breast cancer at the time that they undergo testing, and we'll exclude those who do, as well as those who have already undergone prophylactic surgery. And for this study, we would estimate about 7,200 women who would meet these criteria. So the index event, like I mentioned, will be the time of the test result. We'll be looking from January 2007 to April 2016. For all of these women, we'll also look backwards in time to see whether they developed breast cancer during that period or they had a prophylactic procedure. All the women remaining in our cohort will be followed forward in time to March 2018, and we'll be looking for screening events. We'll be looking for breast cancer, prophylactic mastectomy, and death. From there, so the way that we're classifying the exposure is going to be based on the test result group, and we'll be looking at the 4 groups that I mentioned earlier, so looking at each of these individually. The way that we're defining the outcome, so high-risk screening, as I mentioned, will be the occurrence of both mammography and breast MRI within 1 year, and what we're interested in is the rate of screening, but also the proportion of high-risk screeners in each of those groups, and we'll look at that over time, so at 2 years and at 5 years as well. The covariates that we're using for the study, many of them were driven by the study that was done in the general population, looking at factors associated with the uptake of breast cancer screening. So we'll be looking at certain demographic characteristics, of course, as I keep mentioning, personal and family cancer history, as well as some care-related variables, including whether they have a family physician and where they receive their counseling. Our analysis plan for this study is 2-pronged. So to begin with, to look at the rate of screening in the population, we'll use a recurrent event regression model, where we'll look at the rate of screening over time by test result group, and we'll be able to incorporate both fixed and time-varying covariates for this analysis. And then to look at and compare the proportion of high-risk screeners between groups, we'll use the multinomial logistic regression model. So our trichotomous outcome is going to be women who are not undergoing any screening, those who are undergoing screening that's not high risk, and those who are meeting the criteria for high-risk breast cancer screening. So the aim of the study would be essentially to identify targets for some sort of intervention, probably based around some sort of educational intervention if we do see that those screening rates are high. And the reason why that's concerning is, I mean, although we think of screening as being benign, it's not always the case. So this is a study that recently came out in JAMA Internal Medicine, comparing rates of breast biopsy between MRI and mammography, and really, what's not surprising here is they saw higher biopsy rates in women who are undergoing MRI. And the authors were emphasizing the need to correctly identify women who are most likely to benefit from MRI rather than subjecting all women to MRI over mammography. So from there, I'll move to the final aim of the proposal. So that's looking at the uptake of prophylactic surgery. So again, to put things into context, what we do know about prophylactic surgery and its uptake, again, comes primarily from women who test positive, primarily from survey-based studies. There was this recent study in July of 2017 where they took survey-based information, linked that with SEER in the hopes that they would get a unique cohort. And I don't want you to be bogged down in the details here, but essentially what they were looking at is the uptake of bilateral mastectomy. And what you'll see here is a high rate. If you look at the 85%, you'll see a high rate of women who carried a pathogenic mutation who are undertaking bilateral mastectomy. But what you'll also notice is up to 50% of women with a VUS mutation were undergoing bilateral mastectomy, and even high rates in the 40% of women with negative results. The other thing that I'll point out here are the small numbers. So if you look at the bottom, despite linkage with SEER, we're still seeing groups that have 14 patients, 22 patients, etc. So again, small studies. And this is another thing that came out of the study. They actually surveyed the surgeons as well and asked them how they were managing these women. And many of the surgeons admitted that when they receive a VUS result, they treat it very much the same way as a woman who's found to carry a pathogenic mutation. So for this study, what we'll do is we'll look at the uptake of both bilateral prophylactic mastectomy and risk-reducing salpingo oophorectomy. We'll look at that separately in 2 separate models. So for the study of bilateral prophylactic mastectomy, the women will include are those who don't have a history of breast cancer, haven't undergone prophylactic surgery, and similarly for risk-reducing salpingo oophorectomy, we'll include women who have no history of ovarian cancer, haven't undergone prophylactic surgery at the time of testing. Again, we'll classify these women in the same way, so 4 test result groups that we'll look at and compare. And here the outcomes we're interested in will be the uptake, as I mentioned, of bilateral prophylactic mastectomy, risk-reducing salpingo oophorectomy, as well as the other factors that are associated with uptake of prophylactic surgery. Again, similar covariates, so again, demographics, personal and family cancer history, and some care-related variables that are important here, especially who the surgeon is for those who undergo surgery. And then our analysis plan for this is a little bit different. So as I mentioned, 2 models. There'll be multivariable time-to-event analyses. We'll take into account the competing risk of the relevant cancers that can develop, as well as the competing risk of death here. We'll look at and compare the cumulative incidence functions and then describe both the cause-specific and the sub-distribution hazard ratios. So here, again, I mean, the issue here is, once again, identifying high uptake, because, again, that's concerning. In women who are found to carry pathogenic mutations, we do see survival benefits to prophylactic surgery. There's been no study looking at survival benefits to any prophylactic procedures in the other test result groups. So really there's no evidence for those women undergoing prophylactic surgery independent of their cancer history or their family cancer history. So if we are seeing high rates of prophylactic surgery, that again suggests the possibility for targeted interventions, again around education primarily. So now that I've gone through the 3 aims, I just want to highlight really the significance of this project. As I mentioned, what we're hoping to do is identify those areas where education would be helpful, but also possibly interventions based around risk communication or better integration of genetic counselors after testing. This is just a quote from an interesting phenomenologic study where they interviewed women who had VUS results. And one of the themes that came out of that study was that these women felt that their healthcare providers really lacked knowledge around how to counsel them. So here this woman said, I need a guiding light, someone who has experience and knowledge in this area and supports me. So I guess what we're looking to find is where those knowledge gaps are and what kind of experience or what kind of education can help build that experience for these women. So course feasibility, I think I have on my committee the appropriate content and methodologic expertise to guide this study. I can say as of this week that I now have some experience, although limited, working with ICE's data for a different project. And as I mentioned, the chart abstraction is already 80% complete. I started my graduate work in July of 2016 and have spent the last 18 months or so really building the infrastructure for the project, so that's all underway. And also in the last 18 months, I've taken the 10 courses that would be required of a PhD. So beyond having to take the comprehensive course, I really will be able to focus my time towards the project. So our timeline is we're hoping to be done the chart abstraction by June of this year, and we'll spend the remainder of the year linking to ICES and creating the cohorts. That means we'll be able to do the analysis of the projects in 2019 with some devoted time in 2020 to thesis writing and the thesis defense. Hopefully all of that was clear. With that, I thank you for your time and your attention, and I'm happy to take any questions.
I just want to ask about the age. What age do you use?
So we're just using 18 and older. So there's no, beyond that, there are no age cutoffs. There's no high cutoff. Recommendations for high-risk screening are a bit different if you're under 30. So for those women, the recommendation tends to be annual MRI without mammography, and mammography is only used in settings where MRI isn't available. So we'll definitely have to keep that in mind when we're doing, when we're tackling AIM2 for the study.
Please can you go back your look forward and the chart where you have look back. I think it's in the under AIM2. So yes, correct. Yes. I have a question. I'm not sure if you're able to find the follow-up up to 2018. So particularly if you're going to merge with ICES databases. there most of the databases, they're behind. Probably currently you may have available data until,
Correct.
dependable until 2016 or?
Yeah. So in picking the date that I presented here, this is based on how up-to-date OHIP is, which is where most of our variables will be coming from when we're looking at utilization. So OHIP should be up-to-date for, like, it gets updated so that it's only 3 months behind. So we're not prepared to be linking any time before June. So this is our estimate that we should be able to go back to March of 2018.
Okay. So your goal is to target and tell women what to do based on the results, conditional on the results of their screening information. I mean, do you, or at least communicate the risk information more precisely? Do you know what you should be doing? I mean, like, it's not, like, you didn't present a lot of information on the natural history of women with these various mutations. You didn't present any information on randomized trials with treatment or testing conditional on this information. So, like, if you're going to educate these women, like, do you actually have any information to educate them with?
So that's a great point. And the reason why there's very little data in that area is people have a lot of trouble following these women in time. First of all, the VUS group is a very small group. And then if you want to focus on the women who receive non-informative negatives, although that's a very large group, the actual cancer incidence in that group is much lower than in the women who carry pathogenic mutations.
That's because they're higher than baseline.
Yes. So in women who have strong family histories but still have a negative result, their cancer incidence for breast cancer would be about 4-fold higher than the general population. But again, I mean, you're raising the exact problem with this topic. It's that there's very little data for these women, and it's hard to make any sort of recommendations, and that wouldn't be what we're hoping to do with this. Eventually, as this cohort matures, we would hope that we could follow these women over time and look at cancer incidence and look at mortality. I obviously won't be around in this setting long enough to do that, but that would be the hope. So it wouldn't be to generate recommendations, but if we see that the uncertainty is driving, screening, it's driving prophylactic surgery, then the hope would be, again...
I mean, I guess the thing is you can look and see descriptively what's happening, but your ability to make normative judgments about whether that's appropriate or inappropriate is going to be... It's going to be difficult. I mean, it's great to inform, like, descriptively, but... Yeah,
so I agree with you 100%. Like I said, it wouldn't be to make recommendations for what they should do. For example, one thing that could come out of this is, for example, some of these studies that have surveyed surgeons have seen that they struggle with communicating results because of the uncertainty. But they also, when asked what to do with a woman who receives the VUS results in a study that looked at 24 surgeons only, it was a small study, all of them said that they would refer the patient's family members for predictive testing to see if they have the VUS mutation, which isn't in accordance with what should be done technically. So, I mean, if we do see that uncertainty is driving things, the idea would be, you know, possibility for educational interventions, not necessarily built around recommendations for what these women should do.
One thing I say is Francis Wright recently put out consensus guidelines about prophylactic mastectomy, and the recommendation was to not do prophylactic mastectomy in patients out in the U.S. So although the evidence isn't great either way, we do have some support for certain ways of treating patients.
I just have a related question, and it's around, so you can talk about the outcomes and the women that have gone for the prophylactic surgery in the VUS group and whatnot. And to what extent are you thinking it may be interesting to talk with some, because you don't know ultimately you have the outcome and you can describe it as you see the procedure, but you don't know the extent that it's driven by the healthcare provider or the woman themselves. So
Absolutely.
How are you going to have a way of kind of digging into that?
Yeah, so not in the study that I'm planning to do. I would say that most of the studies that I've seen that have looked at utilization of healthcare in these VUS patients are primarily qualitative. So there are studies that have interviewed patients, there are studies that have interviewed surgeons, so I wouldn't be looking to replicate that data. Certainly there's room for more questions to be answered in a qualitative approach, but I don't think that I would have the time or the capacity to do that as part of this project.
this is a really interesting study. I understand that BRCA testing can be a single gene, 1 and 2 tests, or part of a panel.
Yep.
And panel tests can also confer high risk or variants of unknown significance. So are you accounting for panel test results?
That's a good question. We're not. We actually looked at how many of these women we were able to see underwent panel testing. In Canada, it seems like that didn't really become a phenomenon until 2016, at least when we were digging at Mount Sinai. That being said, you raise a good point because many of these women may have gone elsewhere or paid for the test themselves, and we have no way to track that. So that would be one of the limitations of this, that those sorts of things might be driving some of the effects that we're seeing. For example, if they were found to carry a risk increasing mutation on panel testing afterwards.
Can I ask about the information you're collecting on family history? So how is that how are you collecting that? So are you looking at the mother's, whether or not a mother was diagnosed with cancer? Because we do know behaviorally that women react to their lived experience in their family history. So a woman with a mother with ovarian cancer will be much more likely to have an oophorectomy.
Yeah. So we're looking at first-degree relatives, second-degree relatives, and then maternal, paternal. So the way our variables are set up, we wouldn't be able to distinguish between a mother and a sister.
But you still know first-degree relatives.
Exactly.
And you know the type of cancer.
Yes.
Yeah, good.
And hopefully for many of them, the age at which that person had cancer. Yeah. Yes.
I just about, if you look at these, how different is the cohort from study 2 and 3?
How different is what, sorry?
How different are the cohorts, like the cohort for this one and the next one?
So the cohort will be similar for the study that looks at high-risk breast cancer screening and bilateral prophylactic mastectomy. So those will be similar cohorts. The cohort looking at risk-reducing salpingo oophorectomy will be slightly different. So we'll be excluding women with a history of ovarian cancer, but not necessarily women with a history of breast cancer.
So yeah, I just wanted to clarify. So you are including women with a personal history of breast cancer?
Yes.
In your cohort?
Yes.
Okay.
And for that one study.
And are you looking at risk reduction uptake in that cohort separately?
Yes.
Okay.
Yes.
So what do we know now about those women with a VUS that have a new diagnosis of breast cancer and risk reduction surgery or treatment?
Very little.
Okay.
So there are some studies, I mean, again, this is mostly coming from qualitative studies. And there have been some Dutch studies where they've seen high rates of uptake of prophylactic surgery in those groups, but then many other studies where they see no difference, no effect on anxiety or distress. So really the data seems to be all over the place. Again, very small studies that have looked at that. Yes.
For the group of patients who have variants of uncertain significance, are you looking into the classification of the VUS further, whether it's likely benign or pathogenic?
So we're keeping track of that. We haven't, I haven't discussed how we would incorporate that information. The difficulty is that the two sites that we're using, Mount Sinai and North York, actually classify VUS differently, and that has changed over time as well. So I believe that Mount Sinai, women who have a likely pathogenic result and a pathogenic result are positives. Those who have an unclassified mutation and likely benign are both VUS, and then benign is a negative result. The difference at North York is only women who have a mutation that's unclassified are being classified as VUS. So the idea would be we'd create these groups based on what was communicated to the patient, not one of those 5 ACMG categories. But we're definitely keeping track of that in case we want to do something further with that.
I guess kind of building on that, have you considered looking at whether the classification of the VUS changes over time, like if it goes from VUS to benign or VUS to pathogenic?
Again, something we're keeping track of, but something that is hard to track. So although these women were tested at these 2 sites, they most likely did not have counseling at those 2 sites. So we're limited in the amount of data that we can collect on them. If they did undergo counseling or some kind of treatment at that site, we tend to have more information. But even then, as I'm sure you guys know, oftentimes that information isn't communicated to the patient. And even when it is, it's inconsistently recorded in the chart. Sometimes it's a phone call that doesn't get recorded or an email that's not recorded. So where we can, we're recording it, but what we're finding is that oftentimes we're not able to pick up that information.
This is really interesting. I'm excited to see your response.
Great, I'm glad. Yes.
I assume you don't have any information on breast density in the study, which might affect screening practices. I just wonder if you could comment on whether that you think that might be an issue or.
Yeah, so it might be an issue in the way that we're defining high-risk screening. So definitely one of the things that will be important to do is actually just looking at the data before we plug these things into models. And if we find that, especially in younger patients, or there are groups of patients that seem to be undergoing a lot of MRIs, but not as many mammographies, that'll give us an indication of that. But you're right in that we have no other objective way of making that determination.
Will you be able to identify imaging that's used for patients after they've had the risk reduction mastectomy? Will that be captured?
So we could.
Okay. that is something that's quite variable in practice. So we don't recommend routine breast imaging, as you know, after risk reduction mastectomy with reconstruction. But within the community, certainly our radiology colleagues tell us that there are still some screening tests that are ordered, particularly MRI. And then the other thing is diagnostic imaging. So if the patient presents with a clinical finding post-surgery, then what is the workup and utilization of breast imaging?
Yeah, so that's an interesting point, and that's something that we could look at. Anything else?
Just a small suggestion. I mean, it would be fairly trivial to track resource utilization over time with these groups, because you could just use the ISIS cost macro and estimate cumulative cost with or without some censoring adjustment for your different groups, and that would be another paper.
Yeah, so one of the things that's part of the larger project will hopefully be a cost effectiveness study. Ideally, to do that, we would have some of the cancer incidence or some of the cancer mortality outcomes. So I think that question would get even more interesting as the cohort matures. And that's definitely something that hasn't been looked at since this was instituted in 2001.
But you could do most of a cost effectiveness study just from within the data without a model.
Yep.
So, I mean, not a lot of cost effectiveness analyses have been done at ISIS in that way, but you will have both cost and outcome data in the same cohort. So,
yeah.
You know.
Absolutely, that's a good point. Okay. Well, thank you again, everyone. I've been told that there is an attendance list outside. Don't forget to sign it on your way out.
Okay, so. So I think we're going to let everyone else go, but if the faculty could stay behind, and we have to discuss a little bit. And you have to step out for 5 minutes or so.
Don't go away, guys. Hopefully, we'll be able to
I don't know.
Kelly, how are you?
Sure. I've heard you on the phone. That's what I am. Sorry. Oh, I'm right. Yeah. Great. Good for you. Congratulations. Yeah. Wow. I know it's been a long time, but I haven't seen it. I haven't got anyone. Yeah. Oh, yeah. I didn't know what to I know. I've got this like really sorry. What happened? Okay. What? Yeah. Yeah, it's only my second one. Oh, yes.
We have to discuss and make recommendations to the committee, like pass, fail, if there are any emendations to
Recommendations that I can make for her to change.
Oh, right. Okay.
So general discussion about this proposal.
I mean, it was excellent.
me that it's very ambitious. I mean, I know her timeline goes until the end of 2020, right?
Yeah, we got 2.5 more years, 2 and a bit more years.
And she is basically 80% finished aim 1.
Yeah.
I mean, I guess the thing that strikes me is that there are just many, many components to this. But I didn't understand it just seemed to me that maybe it is perhaps a little ambitious to add on the prophylactic oophorectomy group onto aim 3 too. Like the whole thing seems to be around BRCA diagnosis, breast cancer, screening, uptake of screening and surgery. And then to have the oophorectomy group in there. I mean, is it nice to shed time, but is it, sort of necessary?
I think this is feasible because basically she's going to have 2 years to do her analysis and write up. I mean, what do you think?
Yeah, I think in terms of analysis, though, for the models that she's using, she's done a lot of reading already.
Mm-hmm.
She's started to understand the code, and she's doing another coincidentally that she's fitting in on these actual models and how to implement them. So I feel like she should actually be pretty efficient, and she's very keen.
And there's no primary data gathering. I mean, like it's the chart review. It sounds similarly done. So the rest is just like ISIS analysis. So
Except it's not a new cohort that she's creating for the oophorectomy group.
Cohort.
It's the same cohort.
It's the one that's almost 80% done. So she'll just
use that.
aim 2. She'll just look at people without a previous diagnosis of breast cancer. But with aim 3, it's everybody in that entire cohort.
I see.
Yeah, so there's no new data.
No.
Okay.
No.
Okay.
Yeah, so different exclusions and different set of models, but again, the modeling one.
She's always contacting the same cohort.
Yeah.
Okay.
We have 3 aims.
So the first is like developing the cohort. The second is looking at the effect of those various categories in patients who haven't had breast cancer before on breast cancer screening and prophylactic breast surgery. The breast cancer screening. And the third is for everyone who hasn't had, so if you haven't had breast cancer, it's the effect of those categories on prophylactic breast surgery. And for those that haven't had ovarian cancer before, it's the effect of those categories on prophylactic breast cancer.
The only question that I had is whether aim 1 is a thesis aim. Obviously, the thing that's needed is the cohort to be put together. It's a tremendous amount of work, and so many questions can be answered from it, but is that a thesis aim? Maybe the other aims that she's already pursuing are sufficient. I don't know if number 1 is an aim.
She's not defining it as a 3-paper thesis, so it's this is what she's doing.
are there going to be 3 papers? Sorry.
I mean, she's probably going to have 10 papers.
I think
I mean, she's very
Yeah.
Oh, you can see that. This is like a shockingly good presentation.
Yeah. So,
Like I told her,
Really
she's
good.
going to take this cohort, she's going to read it. Until there's nothing.
Maybe she should relabel aim 1 as a description of who's undergone genetic testing in the province. Yeah. So it's more of a description of the cohort.
okay.
Yeah. I think that's a good point, actually.
Well, because she's going to publish like a cohort, how the cohort's being developed, and then a paper on the cohort itself, and then these ones. So
Yeah, so then it could be 4 papers. At least.
For the cost paper.
Yeah.
I was like, don't add anything.
Well, you know, the thing is,
We told her no.
well, but the thing is, I don't actually think there's that. I mean, yes, it takes time to do a good ISIS analysis, but like not like getting primary data. So once she's set up the cohort and once she understands her cohort, like actually doing the analysis and writing the paper shouldn't take her that long.
yeah, I think our issue is the effectiveness because you don't have the cancer outcomes yet.
No, I wasn't talking about cost effectiveness. I was talking about just sort of the costing. Yeah, like, I mean, you can, each of them will have, I don't know, a minimum of like a year or 2's follow-up, something like that.
For just a description of cost for sure.
So, like, it just, that would be super easy to do. I mean, not that you have to put it in, but it's just, the other thing is completely unrelated to this. This is, like, is there shared decision-making work in this area? Because if there isn't, this was, I mean, these are all, like, highly preference-sensitive decisions. Sounds like the data is, like, not well characterized, not well known. And people's preferences, women's preferences for these outcomes, like having a prophylactic oophorectomy, prophylactic mastectomy, must be highly variable. So like those are sort of the classic conditions for sort sort of shared decision-making interventions, I'm saying.
There are some already.
Yeah, okay.
For breast cancer prevention, anyway.
But not specifically
But
for
they're
this.
for carriers, though, for positive.
Yeah. So maybe, I mean, something for you or like for her in the future or whatever, not related to the thesis, but.
Yeah, I mean, that's what I was going to ask if I asked a question, because, basically, a lot of this is management of people's anxiety, and the testing has not reduced their anxiety, right? So you get a VUS, and that has not reduced your anxiety. So just saying that they have a high rate.
Do I understand that correctly, that 40% of women who had the test but were negative were still having prophylactic mastectomies?
In that
I think so.
Yeah.
but it was very small numbers.
And it's
But
the
even
US,
so,
it's such a different, it's a different.
40% of women with a negative test?
The US.
Okay, well,
This is the problem with the US, right? So you get told you have a mutation in BRCA1 and 2, but it's of unknown significance or uncertain significance or likely benign.
but I thought it was negative. It was in the negative group.
The negative is much lower.
Is it? Okay.
And is that paper in patients with a diagnosis or without a diagnosis? Like, I don't know. Yeah, because, I mean, if your woman comes with a diagnosis, it's a totally different situation.
Yeah.
Like, and that's the cases that we would see the most often, right? Like, patients have a breast cancer diagnosis and then they get a VUS and they're like, oh, I'm just doing it both. Yeah. So, as opposed to someone who has a family history, then gets genetic testing, and then decides to maybe pursue surgery.
I don't know, looks like a very strong proposal with a lot of,
You know the stuff, and she answered all the questions very well.
yeah, and she presented very
We were just saying, as part of the thesis committee, the commitment should be that she has to do her slides for us.
I have no
That's
idea.
a big house.
I didn't do that before, because your group uses that format. for slides.
Sergio makes beautiful. No, we don't use
No, I think it's PowerPoint, but it's like, it's like a Wilson Center aesthetic. Like, have you ever seen Wilson Center?
No, they
have it. Yeah, it's very.
Really?
Yeah.
Very nice.
The same thing. It's beautiful.
Yeah.
No.
Yeah.
I think that PowerPoint has these fuzzy components now, but not that I have any time to look at that. But it has all the same things that it's useful and professional.
Too much tutorial.
Anyway, I think personally, I think she's fine.
Yeah,
I don't have any suggestions.
I'll bring it back.
Yeah.
That's the easy one.
All right. Congratulations. I think we had a few suggestions. One was to kind of reframe AIM-1 more as a description of the cohort. Yeah, because in that, you might be able to make 3-paper thesis that way, right? Sure. That a description of cost would be useful and not so much the effectiveness, the cost. And what specifically you think is the way to go in terms of publishing that?
Well, I mean, the thing is, I don't think you actually need this for your thesis, but it would be an easy thing to do, either outside the thesis, or if you don't feel like you have enough within. If this first paper is not enough, that would be an easy thing. Well, I mean, the thing is, if you show differential rates of testing and mammography and also mastectomy, I mean, what are the resource implications of that? Does it drive up mean cost per woman by $5,000, $10,000, $20,000? So it's just this is a way of looking at the economic impact of this kind of testing, on the province. So it's just, it's a sort of a descriptive costing paper. Those kinds of things tend not to go to the New England Journal, but it is.
Never mind then.
But I mean, it's worthwhile at the logic stuff. You're showing the sort of clinical implications. Now you're showing the resource implications in the second paper.
Yeah. And it makes it easy to do the next one, which would be once you get the cancer outcomes to look at.
It means once you get cancer outcomes.
It'll be long gone by then.
And so then the whole concept of shared decision making and how this is, you have uncertainty in your outcomes for these women, particularly the U.S. and non-informative negatives, and how we need to kind of better engage them with shared decision making. That, I guess, is just obviously you can't make any inferences about that or say anything about that, because that's obviously a limitation of this. And next steps in terms of work, and probably incorporating some of what Kelly's done in terms of shared decision making, the positives, how that could apply to the negatives would be. But you'd have to flesh out your controlling discussion. Okay. Good. All right. Thank you very much, everyone, for coming.
Thank you. That's amazing.
So is there specific paperwork that you need?